Hello, welcome. Hope you're all enjoying your virtual AMIA experience this year. Appreciate you coming to my talk. And so for the next 15 or so minutes, I'm going to talk about some work that I had done while I was at University of Utah in Intermountain Healthcare. But before we do that, just want to disclose that I don't have any relevant commercial or financial interests that would have affected the research here. And some of the learning objectives that we'll see here today is we're going to talk a little bit about some of the competing interests that clinicians might have from different care settings and how some of those competing interests might negatively affect patient record quality, problem list specifically. And then we'll show you how we've tried to measure this specific issue, and then maybe you can take that back and use that yourself. So to start with, we were meeting with some clinicians, some nurses and some MDs, neonatologists, hospitalists of that nature when we were doing some training on the problem list tool that we were working on and building for them. And while we were chatting with them, we had just heard a couple of stories that piqued our interest. One of the stories was they were describing a patient like we see here on this graphic here, trying to illustrate for you. So this patient has, these are the actual problems, the true health status is what I call it, but these are what's actually wrong with the patient, and this is what's on the problem list. But then these clinicians were telling us if this patient goes to some clinician, doesn't matter where we put ED here, but it could be an outpatient or inpatient. When they see that patient, they might add a problem to the list. They might keep a couple, but then they might see things that they don't really care about. For example, maybe you're a cardiologist. You don't care that you've had a broken bone or your immunizations or other things that are on the list. They don't care if you've had a cold or a fever. So they might delete them. They might resolve them, mark them inactive, whatever the case may be. And then when that patient goes back to his primary care provider, he did care about that stuff. And so now if he's keeping on top of this work on the problem list, he's got to reconcile that list. He's got to see the problem that was added. He's got to keep it. He's got to go find those problems that are missing now, that were inactive or deleted. And he's got to go restore those. And so and that's assuming this clinician is going to take the time to go do that. And he even remembers and can figure out which problems were deleted or inactivated. And so you can see how going back and forth, these problems, the problem list for this patient might get out of whack. Maybe this doctor didn't restore all the problems that actually did affect or should be on this patient's problem list. And so we can see that this problem list might get out of whack between these different clinicians. And that's what we wanted to try to study and look into today. And so we thought it was interesting just hearing about it anecdotally, but we didn't really know. And so what we did is wanted to go validate this. We went to this group that meets at the University of Utah. They invite clinicians from the Intermountain Healthcare and also from our local VA hospital. And on the day we went to go talk to this group to explain what we were trying to go do some research on. There was 13 different clinicians there. We had a pretty good debate about what we were talking about so they could, actually understand what we were describing to them. And they agreed after a little bit of discussion that this was, a worthy endeavor of some research here. But they didn't quite know themselves what to look for or how to capture when this sort of scenario happens. And so what they suggested and what we did do was we created a survey, a red cap survey. And where on the survey, we put every possible permutation. So we took all the attributes from our problem lists. What are the types of problems and things that can be on the problem list? What are the possible states? What are the permutations that they can go, from and to, going from clinicians in different care settings? And our basic goal here is to ask these clinicians, these 23 clinicians who responded, what are the changes to the problem list that we should look for to know when this situation is happening? And this situation that we're talking about is tension. We've called it tension just in our paper, if you read it. And just so we had a shorthand vernacular when we talked to all the clinicians, we just called it tension. And so we sent that survey out. These are the truncated results. There was a lot more, but these are just the top scoring items here. So on the left-hand side, these are the types of things that could be on the problem list. There's obviously a lot more because we had more than diagnosis and social history and family history. We also had differential diagnoses or things on our problem list. They didn't care about those. And then we had times 1 and times 2. And so what time 1 was representing was when a clinician last saw a patient. This is what the status of this type of problem was. Time 2 represented this patient saw an intermediate physician maybe, they went to a different doctor in a different care setting, and then this patient came back to the original provider, and this is what the problem list looked like then, or the status of those problems, whatever the case may be. And so we're talking about the shift from time 1 to time 2 with an intermediate physician. And then we gave the clinicians a Likert scale of 1 through 7. How disruptive or how likely is this change going to be to lead to this tension scenario that we've talked about in the previous slides with those pictures? And so we're just looking for anything that had a mean of over 4, right? So it's on the Likert scale. So anything on the 4, 5, 6, or 7 was, somewhat high enough that we thought it would matter. And if it's below 4, then it's probably not going to matter. So we only have these 5 specific patterns that these 23 clinicians thought or rose above this mean of score of 4 that might lead to tension. And so now that we had these 5 patterns, these 5 things that the clinicians looked for, we wanted to go create a reference standard. So our goal here is we want to make a model. We want to do some training and testing on that model to see how well it's going to work, and see if we can go identify these things happening in our problem list, and in production and what have you. So what we did is we took those 5 patterns that we just saw on the last slide. We went to our EDW, our electronic data warehouse, where we have millions of records. And we did a sample size calculation, determined we need 201 problem lists to get this sort of effect size we were looking for. And so these 201 problem lists had, in varying quantities, those patterns that those clinicians were looking at. And then to do some validation on our side, we repeated 8 of those 201 problem lists, so that when the clinicians were scoring them, we could make sure that they were being consistent themselves amongst how they were scoring identical problem lists. We also added in 3 extra problem lists that did not have any of those patterns. So they should, if the clinician scored them, should not have any sort of tension. So it's more to make sure they understood the instructions, understood what we're trying to go for, and ideally they should have gotten a score of 0. That's just sort of validation on our part. And then we put all these lists. We had 212 now with all those extras added in there. We shuffled them in random order. We sat with these clinicians in isolation, meaning we traveled to their locations. We had 3 clinicians volunteer to do this for us. It took them about an hour to go through these lists each. And then we would sit and chat with them, understanding why they scored 1s or 0s, which we'll talk about in the next slide here. And so when they saw this problem list, they have to understand the tension sort of description that we were talking about earlier. And they have to decide if the problem list that they're seeing could or would lead to this tension, and they would give it a 1. And if not, they would give it a 0. And so the inter-rater reliability, meaning between the 3 different clinicians on agreement, they had about 63%, which is a little on the lower side, but it is an abstract concept. And then on the intra-rater reliability, meaning they had those 8 repeated problem lists, and the 3 that should have had 0, how accurate were they there? And they got 100%, so they were completely agreeing with themselves and consistent with the scoring that they did. And these are just a couple of examples you can see. So again, T1, this is the problem list. When the last clinician saw it, something happened in the middle. They saw a different clinician in a different care setting. That's important. And then T2, they came back to the original care provider. And so these are what the problem lists look like. And this far right-hand column with the yellow and blue, we just sort of highlighted the rows that were different for them to save them from having to scan the whole list. They could just jump right to what was different. And, so we had some things changed, some added. This top problem list doesn't look too wild, but this one on the bottom right here has a lot more going on with it. So for example, we look at the fracture of the skull, it was active. And then when it came back to see the same patient, someone had marked it as being in error. And they also added some things. Okay, so these are just a couple of examples. These are 2 of the 201 problem lists, or 212 problem lists. Okay, so we have these 212 problem lists that have been rated by 3 different clinicians, of giving them a 1 or a 0. And so what we want to do is we wanted to do some training on this data. We wanted to figure out what aspects were actually interesting or relevant, what were salient, for us to go create a model that we can actually put into production and go see if we can find this stuff happening. And so what we did is we did some training on this data. We took 2/3 of these scored problem lists, and we were looking for patterns and attributes that these lists had in common that the clinicians were using to give these a score of 1. And when we found attributes or patterns that all 3 clinicians agreed on, meaning all 3 clinicians scored the same problem list the same, they got a score of 3. And then if 2 of the clinicians agreed, they got a score of 2. And if only 1 clinician agreed, it got a score of 1. And so what that looks like here is something to this effect. And so we had, for example, here, this top section here, this is where all 3 clinicians agreed. They were saying if you have a chronic or acute diagnosis that was active and it came back to you in error, we gave those scores of 3. And then in the middle bar here, we're saying if you had a chronic diagnosis that was active and it came back to you as being resolved, we gave that a score of 2. And then I get a little bit more muddy here at the bottom section, but if any of these patterns or things were happening, you got a score of 1. And so what we wanted to do is, now that we had the patterns that we were looking for, and we had a way to score them with these 1, 2s, or 3s, we needed to figure out, how do we classify these problem lists? We need to find a cutoff score, right? So what we would do is we would take each of these rows, the diagnosis from resolved to active, and we would give it a score. But each problem list can have multiple of these things happening, right? Because the problem list has many diagnoses, many things on it. So they're all going to get scores, and we have to aggregate that score for the problem list. So we're just seeing 1, 2s, and 3s here, but a problem list with 10 different items on it could have a max score of 30, for example, if they all hit these 3 scores, or it could have a score of 10, or it could just have a score of 1, right? So anyway, a pretty wide range from 1 to 3 or 1 to 30, in a case of a list of 10, 0 to 30. And so we're trying to figure out, what is the cutoff score? How do we classify these problem lists with these attributes and these patterns as knowing that this problem list might lead to tension or not, right? Do we need to look at a 5 problem list or scores of 5 or 10? And so to figure that out, we did a ROC, a receiver operating curve, characteristics curve. And so to do that, we're trying to maximize the sensitivity and the specificity of how well we're able to capture the most amount, of true positives and true negatives in our model. And so to do that, we created this ROC. And if you're unfamiliar with ROC, all we're doing is we score all the lists, and then we calculate what the true positive, true negative are based off all of the cutoff scores. So cutoff score of 1, here's what it looks like. A cutoff score of 2, what are the true positive, true negatives? And a 3, and a 4, and a 5, and a 6. And I think we went up to 8 or 9, because after that it stopped being any different. And so on this ROC curve, we're looking for the top left point. It's going to give us the most amount of sensitivity and specificity. In our specific case, that number turned out to be 3. So anytime our problem lists were scored with a 3 or higher, we would consider it as being in tension, and less than 3, it's not something we needed to worry about. Okay, so that was our training. The second phase of this data is we wanted to do some testing. So we used the 2/3 of the data to do the training. Now we're going to use the last third of this data, the clinician scored reference data, for our testing. Okay. And so what we do is we take this last third of the data, I think it's like 67 or 68 problem lists. We take our scoring matrix, we apply the scores to all the individual items on the list. We come up with the aggregate score where we add up all the scores for the list. Then we're going to use this cutoff score of 3 to classify our list as being in tension or not. Then we're just going to compute the performance to see how well our model is actually able to classify this. And we know what it should be because we have the clinician scored reference list, the true data. And so here's how we did. Well, again, so we're looking for the true positive, the true negative. Those are the ones that really matter, our sensitivity and specificity. And then the other ones, the false positives and false negatives, are where we're getting some errors and there's some noise. So out of these 68 problem lists, we were getting 83% sensitivity and about 89 or 90% specificity, so pretty decent. And our accuracy and precision was, again, hovering around 86%. So it's pretty good. Obviously not perfect. 100% would be perfect, but we were doing decent. The other way we wanted to try to visualize this data was by overlap. We wanted to plot the data for the problem lists that were in tension and those that were not in tension, and then the scores that they received. And so ideally, if we have a perfect model, the orange and the blue should not be overlapping or touching at all. They should be 2 separate peaks. And so anything we're seeing differently is just because we have some false positives and false negatives. And those are the things where we need to really focus on and look at future errors or, ways to improve our model. And so for example, right here, we had a bunch of problem lists. We had 16 problem lists that had a score of 1 that were not in tension. And then, let's see. Sorry, this one right here. So we had one problem list that had a score of 16. And so this is, a false positive here. It shouldn't be showing here. There should be no peak here. So we'd want to go look at that problem list and figure out why it was being scored. And then likewise, these blue ones over here on the 0, 1, 2, we had, 1 or 3 problem lists with those scores. And so those are the ones where we're having some overlap, and we need to figure out by looking at those problem lists what exactly the issues are, talking to clinicians about it, trying to improve our model. But then the final step, the thing that really matters, right? So now that we have this model, we wanted to operationalize it and actually see if this is an issue within Intermountains. So this is the whole point, right? This is why we did our training and our testing. And so we went and looked at our EDW again. We went for a wide range, or a couple of year range. We did 2015 to 2017 for this. There's reasons for that, but we did 2 years worth of data. And we broke this data down. So we had about 348,000 problem lists. That's through all of Intermountain Healthcare. We broke it down by the Intermountain Medical Center, which is where we were working with some clinicians, specifically like hospitalists, ICU clinicians, NICU clinicians. And then we broke it down even further just to look at the clinicians, the 23 clinicians who helped score, and then the 3 who scored, the 23 who responded to the survey and the 3 who scored the list. So 26 clinicians. They accounted for about 50,000 of these problem lists over these 2 years. And so what we wanted to do is to find out, out of these problem lists, how many of them had any pattern that would lead to tension. So out of those 5 patterns with attributes we're talking about, how many of these problem lists had any of those on those, 1 or more? It's just pretty low. We were seeing, between 3 to 4% of problem lists even had one of those items on it. So it's not a very common thing. And then we were looking to see how many of them actually hit the threshold level of 3, meaning that's what our model was saying should lead to tension. And it's even quite a bit lower. I mean, these numbers like 834 seems like a lot, but when you put it in percentage, it's only 0.25%. So it's very, very low. And I guess kind of what we concluded from doing this after looking at all this data, 2 years worth of data, and coming up with our model and our threshold and our cutoff score is this isn't really a big enough issue for us to worry about. It's not really something that's going to happen a lot. Maybe if we were to go and get a better model, if we were to go to figure out why those peaks were those false negatives and false positives, maybe we can get a higher sensitive and specific model. Maybe these numbers would jump up to 1%, but even then that would probably be questionable as to whether this is really even worth the time. So I guess that speaks well to the clinicians that they're not really messing up the problem list, at least the way that was described to us that started this whole research. So I hope that was interesting to you. We sure enjoyed doing that research. If you have any questions, I'm here to answer them.